Fantastic. Good morning, everyone. We're really excited to bring in this Hip Hope Network webinar to you on basic principles of hip ultrasound by Graf Method. I'm joining today from the traditional ancestral territories of Musqueam, Squamish, and Tsleil-Waututh nations. Really grateful for, I think, the land and waters and that we get to enjoy and play and work in. I want you to reflect on the lands that you're joining from. It's a really exciting day today, and as you can see, we have three amazing speakers. Dr. Sakkers is a pediatric orthopedic surgeon in Netherlands, is a member of several study groups, and he is going to be incoming president of European Pediatric Orthopedic Society, and he works and he reviews for many journals, including JPOB. And he's been a good friend, and we actually collaborate on a number of different projects related to ultrasound. And we actually have one of his students now visiting us in Vancouver, and Ralph. So happy to have you on this webinar. And then we have Dr. Renata Pospischill. She is a pediatric orthopedic surgeon, currently practices in a private hospital in Vienna, Austria. She completed medical training in Vienna and advanced her expertise through residencies in Salzburg and also in the Orthopedic Hospital Vienna. And she's been an active member of EPAS and has been a member of the LLRS as well, Lower Limb Study Group, since 2017. And we have Dr. Hakan Omeroglu. Is a prof in Turkey, and he's someone quite well known around the world. He's been a past president of EPAS. He served as a president between 2023 to 2024, and he represents many other organizations globally. Is an expert in the field of clinical, academic, and societal contributions. We have over 200 registrants from 40 different countries. We're quite excited. So certainly there is quite a bit of interest in this webinar. This webinar will be posted afterwards, those that are not able to join so that they can watch it. And just a brief introduction, most of you know about Hip Hope Network. This network is brought together really to bring in all the people that are interested in pediatric hip health, so that with a one single goal that we want to improve hip health and mobility of all the children that we care for, on the families and children that we care for, no matter where they are in the world. We're all working together to improve their care. So with no further ado, this is over to our speakers. Ralph, take us away. Thank you.
Yep. Okay, let's see if share. Yeah. Can you see my presentation now? Yeah. Is it visible?
Yep.
Yeah, that's good.
Okay. Yes, I'm going to talk about the importance of ultrasound in the hip dysplasia diagnosis and newborn screening. And it might be that after this presentation you have more questions than answers, but that is actually also the purpose, because hip dysplasia is very complicated. As a topic, which I will try to show you in the next slides. Okay, declarations of conflicts of interest. Yeah, I'm consulted in a few companies. Okay, what I would like to show to you is that there are WHO criteria for screening programs, and those are depicted on the right side of the slide. And actually, if you apply these to hip dysplasia screening, that you have some sort of a problem, because we don't meet all the criteria. I mean, the condition is important, the examination is acceptable, it's continuously rolled out and repeated, treatment diagnostic facilities are available. But there is already a question, what is an effective and accepted treatment? Then we have questions about latent, early, and stages. Opinions on who should be treated they are not agreed in the world. And the natural history still also has some discussion. So, and there's also this discussion about cost-effective programs. So you see that in the context of the WHO criteria, screening programs for hip dysplasia don't meet all the criteria that they defined. This is already what older paper, Cochrane database from 2011 about the screening programs for hip dysplasia. And actually, there is not much new information in the sense of large reviews, but in this concluded actually that there is insufficient evidence, inconsistent evidence, and all the studies that were done were substantially underpowered. And actually for the screening programs, they calculated that you needed a study group of around 50,000. I know that they started this in England and in one other country, I don't know which one anymore, but all these studies where too many people dropped out of the study, so we still were not was not able to do this. Okay, here we have a very interesting paper from 2021 showing you the differences in type of ultrasound screening in the different countries. And this is for the European part. And there is also already a big difference between how Americans look at hip dysplasia and Europeans. Actually, the student that is now working at in Vancouver already found out that the way the ultrasounds are done are in the United States and American continent are in the bigger part different from how we do it with the Graf method. But here you can see among the countries, half of the countries in Europe do selective screening and the other half does universal screening. And the timing is also very different in the different countries. So we have countries that it varies from 1 to 12 weeks for screening when the patient is seen, and the average is at around 6 weeks. But also it's not consistent. Very interesting also a paper in the JAMA from 2022 about the detection rates based on screening strategy. So what was found in looking at all the data that the early detection rates and non-operative treatments were higher with universal screening. But there was no difference found in late detection and operating treatment rates. And here the question was raised again, which is often done, is maybe universal screening may cause initial overtreatment without reducing rates of late detection and operative treatment. And well, we go to that later. There are differences between different countries in Europe. In 2023, systematic review and meta-analysis about universal screening. A similar conclusion, universal screening gave significant increase in the prevalence of abduction treatment without a significant reduction in the prevalence of performed surgical procedures. But here also there were remarks that high quality studies were missing in all the studies until 2023. So this is still a very difficult question. Actually, in the last 4 years, there were many papers. Here again, one, the effect of selective ultrasound screening on the incidence and late presentation. This study group found as the biggest problem a large variability in study design and reporting. They concluded that selective screening maybe resulted in a slightly higher rate of late presentation, but the difference was so small that there was discussion about the costs and effort that was done for the small advantage that they found. And they had problems, especially with the methodology limitation in the definitions, because what is the definition of late presentation? In some studies, late presentation was already defined after 4 weeks of age. And other institutions just started with screening at age 6. So it was very difficult to compare the studies because everyone had another definition of late presentation. This is actually also a very interesting one from Finland. Why all newborn screening programs have the same results, a mini review. Again, in this paper, ultrasound universal finds more immature hips, but has not proven to reduce rates of late detected hip dysplasia surgical management. And yeah, maybe the treatment rates are higher in the universal ultrasound screening compared to the selected ultrasound screening programs. But, and this is what I think is what it is all about, and for example, also the difference between the German part of Europe and the, let's say, more English part of Europe. The question is, what are the available resources? Does a country have a good infrastructure for general ultrasound screening? Is everybody well trained in ultrasound of the hip? And clearly that is much better in countries like Germany and Austria compared to the Netherlands or Denmark. And that also makes the difference which screening program is most successful. So there is not one optimal screening program for a country. You have to look at the infrastructure of the country. If you look at the natural history, one study from the Netherlands, over 5,000 infants screened, and they looked, if you looked at normal hips at 1 month, age 1 month, if they were still the same at age 3 months, and they looked at immature stable hips with hip dysplasia, what happened in the second part of the 3 months. And actually around 90% became normal. I did a study on the natural history myself. I looked for all the hips that I could find in the literature that were documented, not treated with hip dysplasia. And I categorized them according to the Graf classification and the follow-up times and what happened. And actually, if you look at the stable hips, let's say between 80 and 95% becomes normal without treatment, if you look at the reported not treated hips, and only the hips that are, let's say, subluxated or luxated have a much lower outcome. And actually, if you look at a predictive value of graph 2A to C, it is very low. Because you cannot predict on the image and the classification of graph which hip is going to be normal without treatment and which one needs treatment. So that is actually the biggest scientific question we have, in my opinion. It is also done in a randomized trial. There was one in 2000 by Michael Benson and colleagues. They looked between 6 weeks and 3 months without treatment, and actually they found no significant difference between the groups that were not treated and the groups that were treated. From the stable hips, graph 2A and C. And after 2 years, still no significant difference in the outcome. We ourselves did a randomized trial with 120 infants, and the control group was the one that had a abduction treatment between age 3 and 6 months, and the research group was actually denied treatment, and there was no difference at age 6 months, and the balance was around that between 80 and 90% became normal in both groups. So actually, the question here is there any effect of abduction treatment in stable hips? What I found was a Cochrane database systematic review from 2022, actually, so very recent, looking if there was any evidence of abduction treatment for hip dysplasia under 6 months of age had any effect. And the conclusions were that, well, they had only 6 randomized trials. There was uncertainty about the true effects. For stable hips, there was no evidence that treatment at any stage had any effect on the development of the acetabulum. And for the dislocatable hips, a delay in treatment to 6 weeks did not give any evidence on an increased risk on surgery. So what we try to do is look at another way of analyzing the ultrasound images as they are made by the method of Graf. And we introduced statistical shape modeling on the shape of the acetabulum on the images that you make with the Graf method. And we were able to find a correlation what was more predictive about the categorization of the shapes and the outcome. And this 120 children is of course not a large study, but actually here might be a new way of analyzing these Graf images that give a more predictive outcome for the children, also in who should be treated and who should not be treated. That is also one of the reasons why one of our students is now in Vancouver, because there is a very large database and we have to validate actually what we found in our paper in radiology to see if we are much better able to predict actually on the ultrasound. And if you ask why is this method maybe more successful, I think the only thing is that you have more data points from the same image. If you have an image of Graf, you have 2 lines with an angle, which are actually only 2 data points. Here you take out much more data out of the same image, and more data means in general for everything more prediction power. So my take-home messages for ultrasound screening is that ultrasound screening is very important for hip dysplasia. Different infrastructures per country will not allow for one optimal screening program. All dislocated hips should be treated, but it is not clear how to diagnose clinical relevant hip dysplasia in stable, well-centered hips. It is also still not clear how much unnecessary treatment is instituted today, and new image analysis techniques might improve the definition of clinical relevant hip dysplasia between age 0 and 6 months and improve indications for treatment. And my last slide, again, good quality images with the Graf technique are very important for optimal image analysis and an optimal selection of newborns that need treatment. And this is my link to the next speaker. Oh, I have to stop sharing my screen probably. Where is it? End show. Joel, can you take over for the next speaker?
Yes, I think Dr. Pospischill should be able to share screen. Let me, there we are.
And I hope I didn't make too much confusion with my talk.
Yeah, good evening from Vienna, ladies and gentlemen. I'm Dr. Renata Pospischill from Vienna, and I've started my training in 2002 in the Orthopedic Hospital Vienna Speising. And throughout my career, I've had countless instructive discussions with Professor Graf, the pioneer of the hip ultrasound screening method. And thanks to the general screening program in Austria, indeed, I've been able to scan an immense number of babies in a short period, allowing me to gain extensive experience in this field. And I strongly believe that once you have learned how infant hips appear in ultrasound images and how and understood the variety of dysplastic hip presentations, you will undoubtedly gain a better understanding of neonatal hip anatomy. And with my presentation now, I would like to provide a short manual that focuses solely on the fundamental principles of the Graf method, emphasizing the essential facts and details. In the late 70s, Graf began his research work in this field, and he published papers mainly in German. And parallel to Graf, Haki, Suzuki, and Teresen have developed their own methods and approaches for performing hip ultrasound examinations, and their work indeed has helped advance the diagnostic capabilities. And since then, Graf's biggest concern was to establish standardized instructional courses in his technique. Therefore, it's a basic principle of the Graf method to teach strict standards in formal courses, as one of the main causes of misdiagnosis are the errors that occur due to informal bedside teaching. And standardized training and quality control measures are essential to ensure consistent and high quality hip ultrasound examinations. Variations in the scanning technique or anatomical or landmark identification between examiners can result in poor reproducibility, even among experienced sonographers. And there are three pillars of Graf's hip sonography, starting first with an exact scanning technique, using a specific hip sonography cradle, and secondly, a probe guiding system to avoid tilting errors. Once you have examined the newborn hip and frozen the ultrasound image, you should begin to work through the first checklist, which is the anatomical identification sequence. This sequence with 8 specific anatomical landmarks ensures that all key landmarks are properly identified on the ultrasound image to avoid diagnostic errors. So first, you start to look for the chondrossus junction, which separates the hyaline part from the bony part in the proximal femur. You may remember that the hyaline parts are the femoral head, the greater trochanter, and the proximal part of the femoral neck. The second is the nut-like or oval-shaped femoral head, which from a geometric point of view corresponds more to an oval joint with physiological incongruity and is never like a truly rounded ball. The third is the synovial fold, which is a turning point where the capsule of the femoral head turns into the perichondrium of the greater trochanter. And its sonographic echo always appears as a rounded spot, or either as a rounded spot or 2 parallel stripes. And the synovial fold must never be mistaken for the labrum. Again, you start with first the chondrossus junction, then you identify the femoral head, then you need to identify the synovial fold, and number 4 is the joint capsule, which is a structure which can be followed from the synovial fold echo cranially over the femoral head and then over the cartilage portion of the acetabulum. The capsular echo ends in fatty tissue under the reflected head of the rectus muscle. Again, start with number 1, chondrossus junction, femoral head, synovial fold, joint capsule. Then number 5 is the labrum, which is the first structure of the acetabulum, and it is attached to the hyaline cartilage roof. Follow the capsule on the surface of the femoral head cranially, and the labrum will be found lying adjacent and inside the capsule. The labrum is seen as a strong echo or as an echogenic triangular structure inside the joint. Again, start with the number 1, chondrossus junction, then you identify the femoral head, synovial fold, capsule, labrum, and then number 6, after identification of the labrum, follow the surface of the femoral head from lateral to medial, and the next structure adjacent to the labrum is number 6, the hyaline cartilage roof, next part of the acetabulum. Medial to the hyaline roof is number 7, the bony roof, with the lower limb of the iliac bone, but please remember the lower limb is not part of checklist number 1. We will come to it later. And at the end of checklist number 1, you must identify the bony rim, which is the most lateral point of the concavity of the bony socket. Briefly, it's the turning point of the concavity of the bony roof where it changes to its convexity. And you should look for it from distal medial to proximal lateral, and frequently you will find there is a small acoustic shadow just medial to it. To finalize checklist number 1, remember, all the anatomical structures must be identified in the correct order. Even if only one structure is missing, you might risk a reproducible sonogram, and a sonogram must not be used. Once we have successfully finished checklist number 1, we follow checklist number 2, which is our usability check. In order for hip sonograms to be comparable among examiners and to be reproducible, it's necessary to establish a standardized cross-section of the hip joint. A correct and identical cross-section needs 3 coordinates, which are the lower limb of the bony ilium, the midsection of the bony roof, and the labrum. We've learned where the labrum is and what the labrum is, but what are the lower limb and the midsection of the bony roof? The lower limb is that part of the bone in the acetabular fossa which is not covered by the lunate fascia. Sonographically, it's really a strong echo in the middle of the acetabulum, and it's more or less the center, and thus the rotation axis for our sonographic planes through the bony roof. In the midsection, the iliac bone silhouette above the acetabulum is always straight and parallel to the margin of the monitor. So if you turn your probe too anteriorly, the silhouette of the iliac bone will narrow its left margin of the monitor. If you turn your probe too dorsally, you will see the silhouette of the iliac bone looking like the gluteal fossa. So only images taken in the midsectional plane of the bony roof should be used for diagnosis. If you're able to see the lower limb, the silhouette of the iliac bone parallel to the margin of the monitor, and you clearly see the labrum, you have finished checklist number 2. And now you follow the next step, which is the description of the acetabulum. That is not a statistical shape modeling, it's really a description which helps you to classify the hips without doing any angle measurement. You do an orientating sonographic typing with the help of special terms describing the acetabulum, and it is based on the pathomorphology of the acetabulum and on the pathological changes of the joint, and not on the degree of dislocation, as we would do that with X-rays. This tool helps to limit false diagnosis caused by incorrect angle measurements and vice versa. And the bony and cartilaginous acetabulum are classified with standardized terms. So first you describe the bony roof, which can be good, deficient, or poor. A bony roof which is good is always in hip types number 1. A deficient bony roof you will find in hip types number 2. And the poor bony roof you will find in dislocated hips in hip type 3 or 4. Next step, you should be able to describe the bony rim area. The bony rim area could be sharp, blunt, rounded, or flat. Hip types number 1 have sharp or blunt bony rim areas. Rounded bony rim areas have hip types 2. And flat bony rim areas have dislocated hips type 3 or 4. And at the end, you need to assess the cartilaginous roof, which can be described as the coverage of the femoral head, because covering is used for centered hips and signifies that the higher limb roof helps keeping the femoral head in the socket. Displaced is the term for a decentered hip, and the femoral head has deformed the cartilaginous roof. So the cartilaginous roof covers the femoral head in normal hips, in hip types number 1. The cartilaginous roof still covers the femoral head in hip types number 2. And the cartilaginous roof is displaced in dislocated hips. And with the help of the description of the deformity of this cartilaginous roof, you are able to distinguish between hip type number 3, which is a cartilaginous roof displaced upwards, and hip type number 4, which has a displaced downwards cartilaginous roof. So now we have strictly adhered to all checklists, and we are able to describe the hips and to classify the hips without doing any angle measurements. But at the end, you should be able to do the measurement technique properly. With the measurement technique, you are able to measure two angles. The first one is the alpha angle, which is the angle included by the baseline and the bony roofline. And with the alpha angles, you are able to do the three subdivisions of Graf's types. So type 1 are the normal hips. Type 2 are the physiologically matured, delayed matured, or dysplastic hips, and type 3 or 4 are all dislocated hips. With the baseline and the cartilage roof line, you include the beta angle. With the beta angle, you do the subdivisions between type 1A and 1B and type 2C and D. If all alpha angles are plotted on a line, with the help of the sonometer, you are able to differentiate the three large subdivisions. So if you look on the sonometer on the right section, all alpha angles above 60 degrees are type 1 hips, which are normal. On the left section, on the left side, all hips with alpha angle below 43 degrees are dislocated, type 3 or 4, and you've learned how to distinguish between them by the help of the deformity of the hyaline roof. And between 43 and 59 degrees, we will find all those type 2 hips. The beta angle helps to do subdivisions in the type 1 and type 2 hips. So in conclusion, if you would like to start with Graf Method, if you're flirting with it, follow strictly the learned checklist to minimize errors and false diagnosis. And with a reproducible and exact hip sonogram, you will be able to do ultrasound-based treatment tailored to exact pathology. But those two things you can only achieve by having an instructional course instead of bedside teaching. Thank you very much for your attention.
Hey, good morning, good afternoon, or good evening, wherever you are, and greetings from Ankara. And I'm gonna talk about the common mistakes by the examiners in the Graf method. Indeed, I'm gonna repeat most of the points which have been mentioned by Renata, but we have to repeat all these important points in order to avoid the mistakes in the Graf method. Graf method is the most widely used ultrasound technique for assessing baby hips worldwide. However, ongoing debate persists regarding measurement variability among examiners, as well as concerns about whether it may lead to overtreatment or fail to detect certain cases that could worsen over time. However, the primary reason for the ongoing discussion surrounding the Graf method is probably not the method itself, but rather the examiner's tendency to deviate from its well-defined rules or make personal modifications to the technique. So I'm gonna talk about the mistakes in the examination technique, mistakes in the image assessment, and I'm gonna give the take-home messages. So what about the mistakes in the examination technique? Graf method is a quantitative classification of hip joints based on the evaluation of static frontal plane images. And stress test is only performed for type 2C hips. And the Graf method includes only definitions concerning alpha and beta angles and hip types, nothing else. So the first prerequisite is to use a cradle for positioning the baby in the standard way. If you do not use it, it is incorrect according to Graf. Second point, Lateral decubitus position is mandatory for making a proper examination. If you do it in a supine or prone position, it is incorrect according to Graf method. It is useful to use a probe guiding system to avoid tilting effects. It is not so easy to find this tool in the market worldwide, but it's going to be useful for you to use it while making your examinations. It is mandatory to use a linear probe. Using a sector probe is incorrect while making the ultrasonographic examination. It is better to use a foot switch to freeze the images, but it is not a must, but it is useful for the examiner to make the examination properly. Another must is, it is essential, it is mandatory to use standing right side image projections for both hips. If you use left side or other kind of images while making the examination, it is not advised by Graf and it is considered incorrect. So what about the mistakes in the image assessment? As Renata mentioned, it is mandatory to check the checklist. What does it include? Anatomic identification on the image and usability of the image. Checklist is similar to the checklist used by the pilots in the airplanes. So as Renata mentioned, chondrosous junction, femoral head, synovial fold, capsule, labrum, cartilaginous roof, bony roof, and bony rib should be identified. If there is no anatomic identification, this image shouldn't be used. It is useless. For example, this image, following a caudal tilting of the image, you cannot see the chondrosous junction, and this image shouldn't be used for the diagnosis. If you use it, it is a mistake. You see two consecutive images taken from the same hip. This one doesn't include the chondrosous junction, and this image includes the chondrosous junction. And when you compare two images, the left side image seems to be more dysplastic, but indeed it is not a standard image that should be used in the clinical diagnosis. This image shouldn't be used, otherwise it's gonna lead to misdiagnosis or overtreatment. So the second point is, as Renata mentioned, usability should be checked. It is a compulsory prerequisite in the Graf method. No standard plane means sonogram has no value for diagnosis, and 3 landmarks should be clearly visible: lower limb of the bony ilium, straight iliac vein contour, and a visible labrum. You see, due to a cranial tilting of the probe, we cannot be able to see the lower limb of ilium, and this image shouldn't be used while making the diagnosis. Also, we cannot see the chondrosous junction, so this image is useless. So we see the 3 consecutive images taken from the same hip, and this is a standard image. This is a posteriorly tilted image, and this is anteriorly tilted image. These 2 images include tilting errors and shouldn't be used. And after making the checklist, we are drawing the lines to make the classifications, but in the daily practice, we see many mistakes while drawing these lines. The first line is the baseline. From the uppermost point of the cartilaginous roof, a tangential line is drawn cranial to caudal along the echo of the ilium. This is essential. You shouldn't draw the line just parallel to the iliac wing. It should be tangential, just a caudal to the inferior part of the ilium. And this point is almost the attachment of the rectus femoris muscle to the anterior inferior iliac spine. The second line is the bony roof line, and a tangential line is drawn laterally from the lower limb of the ilium, just touching the bony roof, not the bony rim. It should be tangential to the bony roof. And we see several mistakes while drawing the bony roof line. And perhaps the most common mistakes is made while drawing the cartilaginous roof line. As Renata mentioned, bony rim is the turning point from concavity to convexity, and there is frequently a small acoustic shadow just medial to the turning point or bony rim. Here is not the bony rim. Here is the bony rim. And the green line is the correct cartilaginous bony roof line. And this is the red line is the false cartilaginous roof line. And there are some quality management control studies, and one is interesting. In the refreshment courses that were organized in Germany and Austria, only 28% of the trainees passed the refreshment courses, and 36% of errors occurred in the measurement lines, and 64% had the wrong anatomical identification or not in visible landmarks, as we mentioned before. So false positive diagnosis leads to over-treatment or unnecessary follow-up, but more dangerous one, false negative diagnosis leads to mistreatment or missed follow-up. I'm gonna show you some examples from the daily clinical practice. For example, these two images were reported as Graf type 1 hips, but I cannot see anything proper that was perfectly defined by Graf. These images have no value, so the report shouldn't be considered. So this 4-month-old baby had a public harness treatment due to diagnosis of bilateral Graf type 2B hips, according to these images. But you see, the images of both sides are not standard images. And when we make the correct ultrasonographic examination, both hips are Graf type 1 hips, and this is a really over-treatment. But this is a disaster. This is a missed case. A 2-month-old female patient had a diagnosis of bilateral Graf type 1 hips, but you see both hips are decentric, and the X-ray of the same baby at 10 months of age, and she was operated on. So we have to follow the rules of the Graf method. And these are the images that in which a diagnosis were made, but you see the mistakes. This is an image, anteriorly tilted image with no lower limb, and this is a posteriorly tilted image. These are several images, and these images had all reports, but these are all full of mistakes according to Graf method. And here is not the bony rim. Bony rim is here. And you see there is no chondro-osseous junction, but you see there are alpha angles, beta angles, diagnosis, Graf 1, 2, 1, Graf type 1, 2, etc. And this article provides an insightful assessment of published studies examining hips initially diagnosed as Graf type 1, which later deteriorated and progressed to dysplasia over time. However, a detailed analysis of these articles reveals a common issue. The well-defined rules of the Graf method were not properly followed. You see this in none of these articles. And a certain example highlights this issue from a journal. The hip reported in this article was unfortunately not normal at the initial ultrasonographic examination. The hip was decentered and the depiction of the bony roof line was incorrect. This is not a case of a hip that was initially normal, but deteriorated over time. Rather, it represents an instance of hip dysplasia that was initially missed. We see many examples in the literature. So the burning questions: does the Graf method lead to overtreatment or fails to identify cases that worsen over time? Or is overtreatment or misdiagnosis examiner dependent due to improper examination and assessment technique? I think the second choice is correct. So my take-home messages are these. Graf method is a well-defined, standard, and reproducible hip ultrasonography technique and assessment method. It is independent from the examiner's experience. Simply adhere to the well-defined rules of the technique. It is mandatory to have a training by authorized teacher in special training courses. Bedside teaching from non-authorized people leads to systematic teaching of mistakes. So I would like to invite you all to the 43rd annual meeting of the European Pediatric Orthopedic Society that's going to be held in Toulouse, France in April. And thank you for your kind consideration. So I think we have several questions.
Thank you very much. And I think this is an incredibly insightful presentation, but also from people that are, global experts in this area and have published a lot themselves on it. But this is, I'm sure there are lots of questions. And so I didn't introduce myself at the beginning. I'm Kishore Mulpuri. I'm one of the pediatric orthopedic surgeons here at UBC, University of British Columbia, and BC Children's Hospital. And I work closely with a team called the HIPPY team. And we have a large database for children's hip dysplasia and many others. But we're also coordinating the whole hip open network with a team that really spans across the globe. With that, I think if you have any questions, feel free to type in or ask, because there's lots of people. I think it'll be very difficult to put in, for me to monitor your hands if you raise your hand. But I think if you turn on your camera, it'll be very easy for me, or just put your questions in the chat. We've got a couple of questions already. One is from Hisham, which is, what is the clinical position of the limb during scanning? Any one of you, maybe Renata, you could probably take that on.
Yeah, that's a very important question, because you might risk tilting errors if the position of the limb is bad. So as Hakan said, it's a lateral positioning in the cradle, and you might slightly internally rotate the lower limb, but be cautious, because if you do too much adduction to the newborn hip, you might risk a caudocranial tilting error, and then you would have a worse hip. So you would make it worse than it is.
Fantastic. And the next question is, when is the Graf Method course that EPOS organizes?
We do not have a specific graph courses, but it is the Graf Method is included in we have BAT trilogy courses that has been organized in Vienna, and the Graf Method is included in the Basic 1 course, and we have a workshop within this course. If you would like to attend the EPOS BAT Trilogy courses, Basic 1, it is possible to have this knowledge.
Yeah, so I think that's great. And David asked a question. I had a similar experience. The question here is it possible to get a false normal hip pitch on ultrasound? I had one, I use it in my presentations, where there's a plain X-ray that's done that clearly shows, if you use IHDI classification, this is more of a IHDI grade 3 or 4, the hip is clearly out. But when you position the kid and put your probe, it reduces the hip. So ultrasound looked normal, but the X-ray looked like a IHDI 3 or 4. So to any of you, I think this question really here is it possible to get a false normal hip on ultrasound? And I think you kind of, Hakan, I think you probably mentioned that in your presentation with the presentation. So Renata, and then followed by Hakan for your comments. Yeah.
Yeah. So I've never ever had this experience, but you might risk that point if you mistake the labrum for the synovial fold. So if you fail in checklist number 1 with anatomical identification and you don't see that you mistook the synovial fold for the labrum, you will have normal measurements at the end and you will have a dislocated hip with a normal alpha angle. But once you have seen that you had made an error in the anatomical identification, you should stop and take a new image. So that's the point, sticking to checklist number 1 and have knowledge about anatomical structures there.
I haven't encountered with such a problem, so I agree with Renata.
Great. So next one is, thanks for great presentations. What frequency should be used, 5 Hertz or 7.5, or a different measurement? Does it change according to baby's age?
So if I'm allowed to answer this question also, you should, if you have a 7.5 frequency, and you will be able then to do hip ultrasound images until the hip ossifies. This means until the ossific nucleus is that big that it makes a shadow on the lower limb and you're not able to make hip ultrasounds anymore. So you will, from the birth up to the age of 8 or 9 months, use the 7.5.
Great answer. Next one is, when do you perform an ultrasound? So I'm assuming, obviously, maybe 2 answers if you can give. One is for if you're doing universal ultrasound screening, when do you perform? But if you're doing risk factor screening, I typically do it between 6 to 8 weeks to differentiate between apples to oranges. But maybe, Ralph, can we ask you, when do you do for universal hip screening? And when do you do if you're only, there are countries like ours that are only doing selective hip screening?
Well, in our country, we are in Europe actually quite late with our hip dysplasia screening. So it's between 2 and 3 months usually. But that is a matter of, how would I say, historic, an historic fact, more than a scientific decision. I mean, it was already there when I started my career in the Netherlands. And, but yeah, as I showed you, there is quite some difference in Europe between, let's say, 4 weeks and 12 weeks spread in which country does screening when. And a lot is dependent on also how the whole healthcare infrastructure is, because we do physical examination screening is done by Youth Healthcare in the Netherlands, which is actually on average better organized than in other countries. So all children go to Youth Healthcare at 4 weeks and they do the physical examination to detect hip dysplasia. And that is, an historic fact more than an evidence-based chosen method.
Okay, great. I think in the interest of time, we'll go through a few other questions. Next one is, should we restrict whatever you said to graph principles? I'm assuming yes, but you can answer that. And if a patient is in a Pavlik harness, when you do an ultrasound, do you take the brace off?
Yeah.
Do you do it with or without the brace?
Without the brace, yeah.
Yes, without brace.
And to all of you, I know we're working on one ourselves. I know there's a group in Edmonton. What do you think of AI to eliminate the mistakes in terms of measurement? Are you guys using any automatic measurements? Are you manually still measuring your percentage coverage, alpha, beta angles?
So I personally don't have any experience with AI measurements. Still, it's the perfect scanning technique and the mid-sectional standard plane. And from that point on, we might start to develop AI measurement techniques that might be an option, a future option, but still we need to do the mid-sectional standard plane by ourselves with the probe. So.
Well, I would think that AI is the future in detecting the mistakes in the planes. And I think AI will in the end be better to analyze the image on what you can see or what you not can see, but AI needs a lot of training. But I think in 10 years, the world will look different.
Several studies are being performed on this issue. We are going to see the results.
Yeah.
Great. And since I see the person that typed in a long questions, I'm going to get him to ask himself. John, do you want to ask the question?
Sure. Thank you everyone for the talk. So, I mean, I'm pretty confident, I'm coming in from Canada. I'm pretty confident that most of our technicians are not holding to the standard that you guys are holding for your graph technique. I don't think we are placing them in a lateral position and using a proper support system. That being said, how often are you actually going to reject an image and force an early repeat image, recognizing that you can still gain some information even if it isn't meeting all the criteria for the full graph standard? I'm just asking from a more practical, obviously there's an ideal, but is there a practical approach, or is there a certain situation where you're like, we absolutely need to send them back?
If I may answer it for Austria, and I can answer one of the following question: who should perform the ultrasound image? So, in our country, orthopedists mostly perform hip sonography. So we are able to do the clinical examination. We are able to look into the hip, so we know how to do the surgeries. So the knowledge about hip is big enough to get a proper image. So we don't have a high rate of rejected hip ultrasound images. And in our country, we have a universal screening where we perform hip sonography twice. So once after birth and once after 6 to 8 weeks. In most of the cases, we have different examiners. So that's good enough to check vice versa, maybe errors, and to have at the end a good ultrasound and the proper hip. So at the end, the rejection rate is not that big as it might assume.
In my daily practice, I perform my own hip ultrasonograms. And if I encounter with an image that is not standard according to me, I repeat the hip ultrasonogram by myself. And I do not follow only the reports, because some patients are referred to me by only giving me the reports. I do not follow the reports. I do my ultrasound examination by myself again. So I trust myself.
Yeah, it's similar to that. We not always follow the reports of the radiologists, but that is thinking more general in pediatric orthopedics.
And we're definitely not. I think we're all independently measuring our ultrasounds as well. At least in my center, I think it would be very challenging for us, even if we have the complete skill to perform the ultrasounds and have them up to the Graf standard, to find the time to be able to ultrasound that many and see the rest of our patients would be challenging. So we are somewhat reliant on the technicians. But yeah, your talk definitely identifies how, relatively speaking, the quality of our imaging is not as precise, and definitely something to consider. But I still do think, I think Dr. Sakkers was mentioning it before, with stable hips, generally the outcomes are going to be quite good with or without treatment. And I'm not saying that as an absolute, but that does allow for some grace, at least, in terms of, you know, risking as much mistreatment and poor outcomes, I think.
Great. So I think in the interest of time, I think there are a few more questions. I apologize to them, but we have our speakers. We can share their email addresses for people if Renata and Ralph and Hakan agree, so that they can reach out to them and for those answers. So a huge thanks to our speakers, and I know it's different parts of the world are joining us from, you know, and to all the participants. I just want to give a big plug in for the next Hip Hope Network seminar is on management sequelae septic arthritis and hip. And that's going to be done in conjunction with CCOT, like how we're doing this with EPOS. And that is done with CCOT. And so some amazing speakers with a lot of experience in dealing with septic arthritis sequelae. So, and there are a few other topics to come, but if any of you have any interest in either moderating or leading or presenting, do reach out to us. And our intent is to really connect the rest of the world with us. One other thing, next slide. So we're actually planning an in-person hip meeting. And, you know, again, stay connected. If you, you know, if you could answer just 2 quick questions, if you can take your phones out, and if you're able to answer this, it will really, really help us to plan. So we want to have a dedicated children's hip meeting that would cover topics like this, but also free papers and research. We figure that any of these meetings, either POSNA, EPOS, COA, POSI, we're not able to have more than 1 or 2 sessions on the hip. But there are many of us that are dedicated hipologists, as I think some people call those of us that are pediatric, interest in pediatric hip, is to have a standalone meeting for children's hip. And that would rotate around to go to different parts of the world. And we may still have a virtual option for people to join, but we really want you to fill up this very short survey. And there is a link put in the chat as well. It'll help us in a great deal planning that, whether based on your interest. Ralph and Hakan, I'm hoping if you could send it EPOS-wise for us, because we're doing this in conjunction with POSNA, and our hope is to do this standalone hip meeting in conjunction with EPOS as well. So when I'm going to be at EPOS in Toulouse, I'd love to chat with you to try and organize this meeting so we can go around the world and trying to make advancements for pediatric hip as quickly as we can. So so just a short survey for you to fill in so we can plan this meeting. I really want to thank our speakers, and you can see right from heart emojis and great talks to excellent webinar to everything that's coming in the chat. And I think that speaks volumes to, I think, our speakers and their knowledge in this area. So with that, thank you so much. Join, you know, Hip Hope Network, stay connected, forward this link to your colleagues if they're interested in pediatric hip. This is not just for surgeons, this is for therapists, nurses, researchers, engineers, anyone that's interested in children's hip, patients and families. Get them to sign up, and let's all work together so no child should suffer from the burden of hip diseases. Thank you, and again, a big round of applause for I think Ralph and Hakan and Renata. And a huge thank you to Tamara and Joel for organizing this webinar. And they're actually really the force behind putting all of this together. So